Good morning, this is Dr. Saeed Al Nasser. Today we are going to talk about pediatric foot and ankle disorders. First of all, you need to know the foot and ankle anatomy in detail, including the bony anatomy, the tendons, including origin and insertion of the most important tendons, and the ligamentous structures around the ankle joint. So the first few slides are anatomy, which you will need to read on your own and concentrate on the medial longitudinal arch, which has implications in the disorders that we are going to discuss later. So we will start from slide number 14 and the rest of the anatomy you need to read on your own. So before we start with the disorders, there are a few terms that you will need to know as the terminology in the foot is slightly different from other joints. The reason is in the foot there are many joints and not a single joint. For example, when we are describing a knee and we say that the patient has a varus deformity of the knee, it is obvious because the knee is a single joint between the femur and the tibia, and if there is varus, that means that the tibia is medially deviated in relation to the femur, and this applies to all other joints. However, the foot is not a single joint, and these terms are different in the foot. So we will need to know the terminology. So to know that, you need to know that there are 4 levels that we can describe, and we will need to know the terms for each level. So we'll start from the ankle and go down. So the ankle joint is the joint between the tibia and the fibula above and the talus below, and usually the ankle has a single arc of movement which is from plantar flexion to dorsiflexion, and if the patient has a fixed plantar flexion deformity, we call this equinus, and if the patient has fixed dorsiflexion deformity, we call it calcaneus. Now to go one level down to the level of the subtalar joint, which is the joint between the talus and the bone below, which is the calcaneum. This joint has 2 movements, eversion, which is an outwards movement, or inversion, which is an inward movement. So if the patient has fixed eversion, we call this valgus. If the patient has a fixed inversion, we call it varus, i.e. when you look at the heel from behind, if the heel is going laterally, that means that the heel is in valgus, or if the heel is going medially, that means that the heel is in varus. Now we go down one more level to the midfoot level at the tarso-metatarsal joint level. If the metatarsals are going medially in relation to the tarsal bones, then we call this adduction or adductus. And if the metatarsals are going laterally, we call it abduction or abductus. The last thing to describe is the medial longitudinal arch. If the arch is very high or higher than usual, we call it cavus deformity. And if the arch is very low, or if the patient has no medial arch, or what we call a flat foot, then that term is planus. So we have 4 levels: the ankle, the subtalar joint, the midfoot, and the arch. And for each, you will need to know the terms that are used in the foot. The importance of this is that you can understand the condition from its name. If we say calcaneovalgus foot, then we know that this patient has calcaneus deformity, which means fixed dorsiflexion of the ankle joint, and valgus deformity of the subtalar joint, and so forth for each condition. So this is very important, and you will be asked about this terminology in the final MCQ exam. Now, to start our disorders, the first topic is what we call clubfoot, and the scientific name is Talipes equinovarus. So from the name you can predict that the patient with a clubfoot has equinus of the ankle and varus of the subtalar joint. We call it a clubfoot because, as you can see on the picture, the right foot is normal, but the left foot is J-shaped, and it looks like the club that the players use in the golf sport, and that's why it's called the clubfoot. The clubfoot is not a scientific name, and the scientific name is Talipes equinovarus. Okay, so this is a congenital deformity that present straight away after birth, but it is present from the first trimester of the pregnancy, from the time of organogenesis, which is usually in the 5th or 6th week of gestation. This is a common condition in pediatrics, and the incidence is about 1 to 2 per 1,000 births, and boys are slightly more commonly affected than girls. Usually it is unilateral, but it can be bilateral in 20 to 30% of cases. The cause of this deformity is not known, and there are many theories that you can read about, but there is no direct cause of the deformity. However, you will need to know that most cases are idiopathic or primary without an underlying cause, and that also clubfoot can be secondary to some conditions like cerebral palsy, spina bifida, arthrogryposis, and other neuromuscular disorders. The detailed pathoanatomy of clubfoot is not required for medical students, but you will need to know what deformities are present at each level that we described earlier. So please go to the next slide. So this is how clubfoot looks like immediately after birth. The feet and the ankles are deviated medially, but if you analyze this deformity, you will find out that clubfoot is not a single deformity. It is a combination of 4 different deformities. These deformities are as follows. First of all, the medial longitudinal arch is very high, So the patient has cavus, and also there is an adduction deformity of the midfoot, and there is a varus deformity of the subtalar joint and the heel, and there is an equinus deformity of the ankle joint. So 4 deformities: cavus, adduction, varus, and equinus. Therefore, we use the abbreviation CAVE, C-A-V-E, which describes the deformities present, and also this guides the treatment, and we treat the deformities in this order: cavus, adduction, varus, and equinus. The diagnosis of clubfoot is purely clinical, and the x-rays do not add any value in its diagnosis. Therefore, there is no need usually to get x-rays, and we will not speak about the x-ray findings as they are not very relevant for this topic. And we will jump to the treatment straight away. So most cases of clubfoot are treated conservatively and do not require major surgical intervention. The standard treatment for clubfoot is what we call the Ponseti method. Ponseti is an orthopedic surgeon who came out with this method of treating club feet after analyzing the deformity on MRI scan. So the treatment starts with serial casting using a long cast applied from the toes to the hip joint, and the foot is manipulated gradually. So we start soon after birth. We correct the deformities in order, as we said before: cave, cavus, adduction, varus, and equinus. So we correct one aspect, starting with the cavus, and we apply a cast, and then after 1 week we remove the cast and we manipulate slightly further, and then apply another cast. And usually most children require 5 to 6 casts, and these casts and this serial casting will correct the first 3 deformities, i.e. the cavus, the adduction, and the varus. And after these casts, the patient will have 3 out of 4 corrected, and the only deformity which is not corrected so far is the equinus. And to correct the equinus, we perform an Achilles tenotomy, which means dividing the Achilles tendon through a very small incision, usually less than 1 centimeter. So this is a small operation which can be done under general anesthesia and sometimes under local anesthesia. And by doing so, we correct the 4th deformity and apply another cast for 3 weeks continuously. And after that, the 4 aspects of the deformity will be completely corrected and the foot will be back to normal. This method of treatment is successful in more than 90% of cases, and only a small percentage of patients will require bigger operations. After correcting the deformity, all the deformities, and after removal of the final cast, we apply an orthosis, special shoes that the child will use for 3 months full time, day and night. And after 3 months, the child will use the same boot during the night only until the age of 4 years. The image of the boot will be shown after a couple of slides. As we said, only a small percentage of children with club feet will require surgery. This is what we call the Dennis Brown boots and bar, which is basically two shoes connected by a bar, and the rotation of the feet is predetermined by the surgeon. This is used after removal of the final cast 3 weeks following the Achilles tenotomy. It is used for 3 months continuously, day and night, and then after that it is used at night time only until the age of 4 years. Now we will speak about a different topic. This is a very important topic. Flat feet is not a scientific name. The scientific name is pes planovalgus. Pes obviously means foot, and planovalgus means, as you know by now, that the patient has two deformities: planus, which means the flat medial longitudinal arch, and the valgus deformity, which means a lateral deviation of the heel or the subtalar joint when you look from behind. So if you look at the picture on the right bottom, the arch is collapsed on the floor, and when you look from behind, the heel is deviated laterally. So the first step in assessing any patient at any age with flat foot is to look for these two deformities. For example, if a mother brings her child because she is concerned that he or she may have flat feet, you will need to look for these two deformities. So you ask the child to stand, you look for the arch to see if it is flat or not, which means planus, and you look at the heel from behind to see if it is laterally deviated, which means valgus. If the patient has these two deformities, then you confirm the diagnosis of flat foot or flat feet. Once you establish the diagnosis of flat feet, the next step is to determine whether this patient has flexible flat feet or rigid flat feet. This is the second step in assessment and is very, very important. To do that, we do what we call the Jack test, which is shown in the next slide. This is the Jack test, which is a very simple test. Basically, you dorsiflex the big toe of the foot, and if the two deformities are corrected, then that means that the patient has flexible flat feet. By the two deformities, we mean the planus and the valgus. So you dorsiflex the big toe. If the arch appears again, then this means it is a flexible flat foot. And if the heel moves from the lateral deviation to the neutral position, then again this is flexible flat foot. So to assess any patient with a potential flat feet, first of all, confirm the diagnosis. So look for the planus and the valgus. If this is confirmed, then the next step is to perform the Jack test to know whether it's flexible or rigid. Now, from now on, it becomes easy. So we will discuss different scenarios, and then this is all what is needed for you to know about flat feet. First of all young children have flexible flat feet. So all babies are born with flexible flat feet, but the parents do not notice the flat feet until the child starts to walk. So generally after the age of 1, they will start bringing their children to the clinic to get assessed for possible flat feet. And at that age, all children will have flexible flat feet. And this flexible flat feet continue to improve, and the arch continues to develop until the age of 7 to 8 years of age. So at 7 or 8 years of age, 85% of children will have normal arch, and only 10 to 15% of them will continue to have flexible flat feet permanently. Okay, so if you have a patient under 7 years of age, it is expected that the child will have flexible flat feet, and there is no need to do anything, and no need for any treatment, no need for any insoles or special shoes or anything, because there is a potential for self-improvement. If a patient comes to you after the age of 8 years with flexible flat feet, then you will need to explain to the parents that this is most likely will continue permanently, and if there is no pain and no other symptoms, then there is no need for any treatment. And most people who continue to have flexible flat feet during adulthood do not complain about anything at all throughout their lives, and they can do their activities normally, and they can play sports without any problems. Only a small percentage of people with flexible flat feet will have pain, usually from the adolescent age groups and older, and this is usually associated with obesity. In this case, if the patient has flexible flat feet with pain, and the pain is not explained by anything else, and we are sure that it is caused by the flat feet, then they can be given medial arch support insoles to be put inside their shoes, and this will correct the biomechanics of the foot during the gait cycle, and it will improve their pain. However, it will not improve the medial arch at all, and they will continue to have flexible flat feet permanently, as we said earlier. Now, in the case of rigid flat foot in children, which means that when you do the jack test, the two deformities do not correct, that means that the patient has rigid flat feet. Or it can be on one side, so it can be rigid flat foot. In this case, there is always an underlying cause, and almost always this patient requires surgical treatment. The most common cause for this in children is what we call a tarsal coalition, which we will show in the next slide. Also, other causes can be responsible for rigid flat feet, as outlined in this slide. Now, the word coalition means fusion, and tarsal coalition means an abnormal fusion between two tarsal bones, usually in the hindfoot. The most common coalition is the calcaneo-navicular coalition, and the second most coalition is the talocalcaneal coalition. This abnormal bony fusion between two tarsal bones restricts the range of movement of the hindfoot. That's why the patient with the flat foot will have a rigid flat foot, because there is no movement at all between these joints. And the treatment for this is surgical, to remove the bony bridge between the two bones. But to reach a diagnosis, any patient with a rigid flat feet or flat foot will require a CT scan and sometimes MRI scan to look for the coalition. Please note that most children or adults with flat feet will have some degree of Achilles tendon tightness, and vice versa. So a patient with Achilles tightness can contribute to flat foot deformity as well. There are some X-ray findings of flat feet, and we do request them sometimes to help with the diagnosis and sometimes to plan surgery, but you do not need to know the details of these X-rays. So to summarize, young children with flexible flat feet do not require any treatment, and you wait until the age of 7 or 8. Um, After this age, flexible flat feet do not require any treatment if they are asymptomatic. If the child starts to develop pain, and this, if it happens after the age of 10 or 12, then a medial arch support insole can be used inside the shoes, and that will deal with the symptoms, but will not affect the flat foot, and the child or the person will continue to have flat feet indefinitely. In the cases of rigid flat foot, you will need to refer the patient to the orthopedic clinic, who will get a CT scan usually to look for tarsal coalitions, and if that's the case, the patient will require surgery. One more scenario which we have not talked about is flat feet in adults, i.e. if the patient comes to you and tells you that he has never had flat feet before, and then gradually started to have flat feet, let's say over a few months period. So let's say if a 45-year-old man comes to the clinic and says that the right foot started to become flat over the last 3 to 4 months, then we call this adult acquired flat foot, which means that it is a flat foot that started during adulthood. The assessment of this patient is exactly the same. So you confirm the diagnosis first by looking for the two deformities, the planus and the valgus. And if it is confirmed, the next step is to do the Jack test to see whether it is flexible or rigid. And the treatment is also the same. If the patient is asymptomatic, then it can be left alone. And if it is painful, then we can give him an insole to use, and that usually helps with the symptoms. Obviously, flexible flat feet that remain symptomatic even after using the medial arch support will require surgery. But the difference between this type of flat foot and the pediatric flat foot is that the adult acquired flat feet are caused by a dysfunction in the tibialis posterior tendon. The tibialis posterior muscle originates from the posterior aspect of the tibia, as the name implies, and insert on the navicular bone over the medial aspect of the medial arch. The main or one of the main functions of the tibialis posterior tendon is to maintain the medial longitudinal arch. In the cases of dysfunction, this arch will start to collapse until the patient develops flat feet. The causes for this tibialis posterior dysfunction is usually degeneration caused by age and weight of the patient. But it can also be affected by other problems like trauma, lacerations to the tendon, and by inflammatory conditions like rheumatoid arthritis, causing synovitis of the synovial sheath of the tendon. Obviously, all surgical details for all of the topics that we discuss are not required from you at all. In diagnosis and treatment of flat feet, stick to the audio description that was provided in the slides. This summarizes the way of assessing patients with flat feet, and the general treatment in general. No need for any further details. Obviously, if you have any questions about this topic, we can discuss it in the clinical sessions. Now the third and last topic in this lecture is metatarsus adductus. Metatarsus adductus, as we discussed in the DDH lecture, is one of the packaging disorders caused by mismatch between the size of the baby and the size of the uterus. This causes the feet to be pushed to the medial side in the intrauterine position, leading to this deformity. This is generally self-limiting in most children, and it continues to improve in the first 2 to 3 years of life, and most cases resolve spontaneously. If they don't resolve, then they will need to be seen by the orthopedic surgeons, and they are usually treated with serial casting to start with, and sometimes they require surgery. The most important part or the most important point to notice is that all packaging disorders that can be seen at birth, like the metatarsus adductus and like torticollis and like calcaneovalgus feet, they point toward DDH. So if we see any of them, we will need to go and look for DDH, and this child will require an ultrasound scan at 6 weeks of age to check for the possibility of DDH. This is a classification for the severity of metatarsus adductus, but you do not need to know this classification. The way to diagnose metatarsus adductus is by looking at the lateral aspect of the foot, which should be straight. If it is curved, then this indicates metatarsus adductus. Also, we can use what we call the heel bisector line, which is basically drawing an imaginary line in the center of the calcaneum, and this line, if you continue with it to the toes, should cross between the second and the third toes. If it crosses more lateral than that, then that indicates metatarsus adductus. The more lateral this line crosses the toes, the more severe the deformity. And as for most congenital deformities or deformities present at birth, we always try to know whether it is flexible or rigid deformity in order to predict the prognosis and to plan treatment. Now, these three conditions are the only conditions required for the examination purposes. Most importantly are the audio explanation that I have provided, so please concentrate on these things. Okay. There is also a couple of topics required from you, which are in-toeing in children and coronal plane deformities of the knee in children, which will be provided in a separate audio.